Welcome to Mind Over Matter. Today my guest is Dr. Max Baranovsky, who is director of the Russian Psychiatric Clinic at St. Elizabeth's Hospital, and we're going to be talking about depersonalization.
Yes.
So obviously I think we ought to begin with perhaps some ideas of yours about what is that exactly.
Yeah, there's many definitions of the depersonalization, and there's no consensus. I use the definition some other physicians come with, that this is a process when the emotional component of perception, memory, feeling, information in general, for some reason cut out. And the person left with the feeling of unreality, strangeness, kind of dim emotions, and it's kind of a natural experience. At the same time, person aware that he is departing from the natural, complete life.
Mm-hmm. Okay. And you see this?
We cannot see it, but we can hear if we will ask right questions. Usually it's rather embarrassing, and even by the person who experienced poorly understood condition, they're lost at words, and unless we'll ask, it's rarely they volunteer with. There's a certain form of depersonalization which is called anesthesia psychica dolorosa, really painful condition. So people cry for help, they feel inhuman, they lost, let's say, attachment and love for their children, or for their profession, or for their art. They feel inhuman, and then they volunteer with it. I'd like to add that really, when we try to picture and understand depersonalization, it's helpful to compare that with analgesia. It's like anesthesia. It's really, for some reason, different, huge stress and pain, our human system, and in brain particular, self-imposing depersonalization, anesthesia, analgesia.
So you're saying that basically it's a defense mechanism that protects people from getting overwhelmed by an emotional reaction?
I would support this notion. It's really protects from further deterioration and explosion. And it runs, by the way, from normal experience to pathological experience. It's not necessarily only illness or the symptom of disorder. It happens usually under huge stress, loss, in immigration, like for instance in our Russian population, Russian immigrants. It's caused by some stress of the some substance abuse. Let's say there's it's known if person smokes marijuana, kind of a high-grade, potent marijuana, within 30 minutes, they have depersonalization. And this is defense. You're absolutely right.
So when you say, let's say with marijuana, you have depersonalization, I'm still not exactly clear. Say, what am I experiencing? What is your understanding of what I'm experiencing?
Yes, the person experiences feeling that he is not present here, that he is unreal, that his body doesn't have weight, that the people around him are really detached, that the objects, they are not quite material, and they don't have any distinct emotion. Their thoughts and memory feels as if it's just a notion and not real thing. They feel suspended. It's like as if they perceive life through the film and not like really touching the substance. It's anesthesia, it's detachment. Maybe it's very good for the nervous system, but it's very painful for the personality because it's unnatural, and we suppose be whole and be integrated and to perceive things, all their life in all their aspects, and that's not happening in depersonalization.
So unnatural in what respect?
Well, unnatural because if we're sitting with you and you perceive yourself completely, you're in charge of your thoughts, you look around, you see objects of furniture, and you know that you're here and it's real, and there's no interrupted connection within you or outside of you. In depersonalization, it's really like insulation. You're in a deep black box, you're just barely hearing something outside, and you know that it's not supposed to be this way. It's self-induced anesthesia through certain psychological and biological mechanisms.
So if I'm experiencing it, I'm aware that of this detachment. I mean, if I can...
Yeah, and this detachment, especially initially, will be very painful. You're fighting it. You're not accepting it. It's like ill. You're not accepting fever. You're not accepting pain. You don't accept arrhythmia. You want it to go away, but you're helpless.
Well, but then again, what about some of the other psychological defenses? For example, when do you see denial, for example, and how do you contrast denial, say, with depersonalization?
Well, denial is important mechanisms, but I think it's less complicated and it's different.
Which is less? Denial is less?
Denial, I think, is less. I think it's less because, you know, in denial, you don't see the thing the way they are, and as you know, you just using a rationalization or something else, you distorting it, but you are really not out of reality. You still feel yourself as real and environment as real. In depersonalization, you know that this process denies you complete, real perception and pleasurable experience of interaction. So they are different.
And it's not a pleasant experience?
No. Very rarely there's a depersonalization when there's a more colors, they're more kind of distinct, but it's an exception. Usually it's a negative experience. I would say like 99%. It's negative. We want to be a whole person. We don't want to be depersonalized. But it's not like a loss of the ego. It's really change, like muted ego and muted perception. And the patient, at times, they're lost at words because for them it's very difficult to let us know as a physician what's happening. So only by sort of careful questioning we come to identify it, and then we have to ask ourselves what to do about it.
Well, we'll talk later about the what to do, but how do you go about kind of, what are some of the questions, for example, that you might ask, or how do you?
I usually ask, do you feel any changes in yourself? Do you feel different? What's painful for you? And some of them, they have like a special look, like a little bit like bewildered, confused, really painful. It's like a glassy eyes at times. It's not like 100%. So you ask him, do you feel incomplete, in touch with yourself? Are there any obstacle, any film? And then you can see that they feel even relieved that someone can formulate what they at loss with words to explain. And you go in usually through the perception of yourself, perception of memory, perception of thoughts, perception of environment. And by questioning it, you are establishing presence of this phenomena. And then I just jump to the clinical and treatment things. Then it helps us to understand why, let's say, antidepressants or antipsychotic, even electroshock therapy did not do a thing, because the experience shows they don't go to the heart of the matter. They're missing. And this refractory, as you well know, refractory depression resistant, which are lingering, That's when we have to ask, and is there depersonalization? Depersonalization, like freezing, protects from further deterioration, but denies us the opportunity to liberate the patient from the clutches of depression.
But I'm sorry, I'm not exactly sure. What interferes with the liberation?
Depersonalization. Depersonalization is like conservation, like immobilization. Mm-hmm. You can look at it as like immobilization of depression. So how you can free a person from depression when they has another layer, crust of depersonalization? It will be futile attempt. Mm-hmm. Futile attempt.
So you're saying that really it is a lot of what explains refractory depression?
Partially, yes. Partially. Not exclusively, yes. Partially, yes. There's a so-called depressive depersonalization syndrome. We don't pay enough attention to this condition, but I will agree with the physician who will say this is why this depression is refractory.
Mm-hmm. And is it what it sticks because the fear of as with say defense mechanisms, the fear of growing beyond it is intense?
Yeah, because you know you're absolutely right. It's self-induced anesthesia, and usually it's done through so-called, known to you, endorphins, opiate-like substances, and they protect and reduce pain. The next step, if the anxiety, depression, depersonalization, will be hallucinations or delusions in psychotic depression, for instance. So they really stop the tendency, and therefore, psychobiologically and in social aspect too, their defense mechanism. They're closing the door, it's like protection, no further psychosis. It's not psychosis, depersonalization is not psychosis, but the next step
might be.
Yeah, and what's interestingly, and I've seen these cases, when somehow through certain means you remove depersonalization, there could be two outcomes. Either is smile and thank you, or could be worsening. It could be florid hallucinations, florid delusions. It's just you unleash something.
Well, you know, we'll have to take a break, but maybe we can pick up with this and talk about who is vulnerable and kind of when do you see it. So we'll take a break. Thank you.
Sure.
AT&T Broadband of Norwood and Westwood will hold a 6-week workshop in video production to train local volunteers. The workshop will teach volunteers how to use camcorders and studio cameras and also train them in lighting for the sets, creating graphics, post-production editing, and audio engineering. AT&T Broadband currently uses trained volunteers on many programs such as town meetings, high school sports coverage, the 4th of July parade, and high school graduation. Workshops are held at the AT&T Broadband Studio located on 375 Vanderbilt Avenue in Norwood. The workshops are free of charge. Volunteering your time will help bring local events and programs of interest to your community. To register for the workshop, contact Kerry Darris or Jerry Comic at the AT&T Broadband Studio at 781-769-7668. That number again is 781-769-7668.
The road to recovery for cancer patients is often long and challenging to overcome. Although cancer treatments today work better than ever, temporary side effects can make patients feel too sick to drive or take public transportation to their appointments. For those without family or friends living close by, the lack of transportation may mean missing treatments that could save their lives. Here's where you can help. The American Cancer Society's Road to Recovery program is seeking local volunteers to drive patients to and from their appointments. If you have a car and are able to donate any amount of time between 9 a.m. and 5 p.m. weekdays, you can really make a difference in the life of a cancer patient. Or for more information about the Road to Recovery program, please call 1-800-ACS-2345. That's 1-800-ACS-2345.
You know, perhaps we could continue with a question about when do you see this phenomena, and then obviously continue perhaps talking about the kinds of questions that a clinician needs to ask in order to help a patient talk about it.
As a rule, it happens in acute stage of disorder. It's in onset of the mental illness, where you have acute symptoms, or it happens after the panic attacks, intense anxiety disorder, in a grief reaction with sudden loss. So it's really shift such a painful that system have to do something to reduce the pain.
Okay. So, okay, maybe then how, for example, well, perhaps the question is more who's vulnerable, because, for example, in situations like that, many people develop the PTSD type symptoms.
Yeah. It's hard to say. The impression I have, and the data from literature, especially written by Professor Nuller, who's practicing in Bechterev Psychoneurological Institute in Russia, he really find out that there are special premorbid organizations, special childhood, it's special children. They are very, in a way, more vulnerable than average child. They're more sensitive, they have more fantasies. They are almost constantly at fear of losing their parents. They're very passionate and altruistic in a way. They not just worry about their own health. They worry about their friends, about the whole world. There's a lot of what you call sympathetic atonia. There's a lot of the anxiety inside them, and it's reflected in such conditions as myositis, the tension of the muscle, especially in the cervical area. They're easily startled, they're poor sleep. So they're, you can say they're prone to anxiety, they're vulnerable. And when something happens, they're really at risk of acute depersonalization. So this type of young people, children, are at risk of developing depersonalization. And luckily, at times it's just a very short period of time. And it's not necessarily always mental disorder. It could be protective defense, which go away and which is appropriate, but not always. It could be lingering, and then it's sponsoring really psychotic symptoms, such series through estrangements. We can think about it as delusions of mind control. It's way back.
Mm-hmm. Mm-hmm. Yeah. So I still, though, I'm a little bit troubled. I'm not sure. You're talking about overwhelming emotional experiences, and therefore, what sets in motion, say, a PTSD response as contrasted to a depersonalization response, as contrasted to, say, denial?
Yeah, it's hard to say. My impression that it's not sufficient to have traumatic event, some stressful experience. You have to have certain organization of your personality and your brain mechanism. You have to have something already prepared. It's almost like on a genetic level, certain response through, let's say, excessive and quick release of beta endorphins, which are analgesics, And they really create situation when the people feel that they are unreal, they are alienated, and the environment is not real. It's like under anesthesia. So event itself is not sufficient. If we will put, let's say, 10 people through the same horrible experience, not all 10 of them will develop depersonalization. So it depends what you have in stock, what's your pattern of responses, but it's more theoretical question and needs more research.
Okay, but based on your experience, then what contributes, say, to a vulnerability to depersonalization? Maybe you could elaborate a little bit on that.
Well,
the childhood.
yeah, I think that some deprivation or traumas, abuse in a childhood definitely contributes. But at times you can have a really good support system, good parents, nothing extraordinary. And this just through the genetic biological unfolding of your potential, person is vulnerable, and threshold of the decompensation to anxiety stimuli is very low. So they could have a wonderful and family, and the parents do everything they're supposed to do, and nevertheless they develop depersonalization. And it's probably like a spectrum. You can have cases where you have more biological factors and other where they're more traumatic psychosocial experience. But you have, I agree with the people who think that you have to have this readiness for excessive secretion of the endorphins. I think that's now it's a leading theory what biochemically supports depersonalization. It's really the opiate, some dysregulation of opiate system.
Okay, so then the vulnerability may well have to do, you're suggesting, with a kind of a genetic predisposition?
Yes, I would agree. I would agree with this speculation. Okay. Yeah.
And back to the kind of clinical interview, perhaps you could dwell a little bit on the kinds of questions you asked to try to help me describe it to you.
Well, I ask people how they feel, what changes that they feel in the self, do we feel completely real, what is unreal, how they feel about themselves, if their perception of their weight or thoughts or emotion or feelings toward themselves or the family is the same. Did they lose interest to certain things? Do they perceive distinctly and clear the environment? If there some like a membrane or film between them and other person, is their life is really full or not? And of course, as you know, it's very refined, and there could be overlap with symptoms with the formulation which sounds as non-depersonalization. However, in general, and this feeling of estrangement, alienation, reduction of emotional component of information will be decisive. And then a history and the history of what medication was used and what was the outcome.
So you're suggesting that if I suggest to a patient that my assessment is depression, you're suggesting that I might be missing a dimension.
Maybe. I hope not. Well, but it's common. I missed it many times. Sure. It's like in psychiatry, as you know, there's a lot of conditions with the asking our proper questions. Our patients who are suffering a lot, they rarely come to you with a complete report and formulation of what's happening to them.
But are you concerned that you might be, do you know the expression leading the witness?
Yes, yes. So you ask them to give examples, yes. But at the same, yeah, it's a careful process, and we should not lead, and we should not put words into their mouth.
But you use the word film, for example.
Yeah, I took this word from them, from the patient. It's not my word. It's like insulation. They use a lot of phrases that you even kind of would not think of. And you, by using the experience, you try that and apply to this group, and you see the response. Let's say, like in a general medicine, as you know, internal medicine, you have to ask certain questions. So why not in a psychopathology? You're asking, do you have pain? When you have pain, before the meal or after the meal? When you have fever? Why we should be different?
Well, I don't think we should be different, but yeah. I gather I tend to ask a whole series of questions that may be different in some respects from some of the questions that you ask.
Absolutely, and it should be this way. We should not be like literally duplicate each other. It's individual style, and it's a combination of open questions and the certain questions. It's everyone does it in their own unique way.
Right, but a little bit at my peril, perhaps you're suggesting that there are a certain number of questions that if I don't incorporate them into my interview, I may miss out in terms of a proper assessment.
Perhaps.
Because part of it is, Max, that I tend to be a lumper, not a splitter.
Okay,
in other words, I tend to sort of put a lot of things together, like anxiety, social phobia, PTSD, anxiety disorders, as variations on depression.
Yeah, include questions about feeling of unreality, about the disappearance or reduction, especially painful reduction of feelings, and you'll be surprised.
Well, and what am I likely to hear?
At times, usually when I hear that, how do you know?
Oh, really?
Yeah.
It's that quick.
How do you know? And there's some relief, as if someone finally can kind of describe what they're vaguely perceiving inside.
Mm-hmm. So you must have some patients then who also say no.
No, of course, yeah. And of course, if they know, and usually they're right. If they're not supported this way, usually you have to just move ahead and look for some other aspects of syndromes and disorder.
Well, we'll take a break, but perhaps after the break, if you could, perhaps you could give us some clinical vignettes, you know, some experiences you've had in assessing people. And then I think in the final segment, perhaps we'll talk about suggestions you have about proper treatment.
Okay.
So we'll take a break. Thank you.
So someone comes up to you and says, do you recycle? And how many acres of Brazilian rainforest can be saved if you just recycled that newspaper? What difference does it make anyway? Heck, you've probably never been to Brazil. Brighton, maybe. And there's no rainforest inside 128, so why should you care? You know why? Because it's the right thing to do. It's like brushing your teeth or eating your vegetables. Well, brushing your teeth. Hey, every little bit helps, and you know it protects the environment. Interested? Call 1-800-CLEAN-UP and recycle. A little effort makes a big difference. So you don't recycle. What's your excuse? Are the bins too heavy? Perhaps there's just too much bending involved, or you think maybe there's not enough trash in the world. I know. Those recycling bins, they're the wrong color. Oh, you might break a nail on one of those plastic milk jugs, or maybe you're waiting for a professional wrestler to endorse recycling. Well, get real. People recycle because it's the right thing to do, and every little bit helps. Interested? Call 1-800-CLEAN-UP and recycle. A little effort makes a big difference.
Every day we throw away tons of trash that could easily be recycled. Every week in Massachusetts, we throw out almost 1 million newspapers. We use more than 9,000 plastic bottles every minute.
But only about 25% of them are recycled.
Some people think recycling takes too much time or it's too hard. This is going to be our world soon.
Help us take care of it.
Recycle.
It's one place where a little effort
Can make a big difference.
I know what you're thinking. You're thinking too many recycling rules. What do you think this is, the Army? Soldier, take apart that tank! Come on, you're still trying to rip those stupid little rings off bottles, aren't you? And those hours that you spent peeling labels? You could have been watching TV. Hey, that's living in the past, people. If you like rules, read the tax code, but this is recycling. Just drop it in the bin. This isn't brain surgery. Interested? Call 1-800-CLEANUP and recycle. A little effort makes a big difference.
Well, perhaps you could illustrate with some experiences you've had assessing individuals and kind of what that's been like for you and for your clients.
Yeah, I remember the case of the young couple. They were traveling from one city to another, and there was a train wreck, and unfortunately the fiancé, the young man, received serious injuries, and he was hospitalized. And the lady came to the office, and well, she was brought to the office because really family felt that
the same day, or
within a week.
Within
a week.
So she was home with her family for that.
Yeah, she was home, and she was really barely talked about what happened. She was really like numb and frozen. And when we start to interview her, to talk about her experience, she reported that she still does not feel that she had this trip, but she knows that she traveled.
Well, let me just interrupt though. The week she's at home, is she getting up and getting dressed? Is she eating, or is she?
It was more like slowed down with some psychomotor retardation, but yes.
So the family didn't initially think that there was a problem?
Yeah, it was like natural. You expect that when there's a loss and tragedy, a person is upset. But for this lady, she was felt very uncomfortable and even guilty that she really does not grieve and have appropriate emotional response to the tragedy, to this injury, as if she is a human, as if she has no feelings. She had full understanding that she lives on a certain street, in a house. She knew that it looks like her home, but she did not feel like she belongs, and there was something different. It's like decoration. It's not real house. And because she felt inhuman and it's not real, she had suicidal ideation, and that's when the concerned family brought her.
So for 1 week, she slowly sort of became more dysfunctional and...
dysfunctional, I would say immobilized.
Immobilized.
And was not able to relate her internal painful experience, but it was evident enough to conclude that she is in distress, and this is some kind of a psychological distress. She was brought to primary care physician and then to our clinic.
And how did you assess that situation? Or?
Well, there was something kind of unusual. She was natural initial impression that it's just depression. Maybe there's something in a direction of catatonia, but she was able, with the help, really describe that she said, "I'm not myself. I'm not human." But it wasn't a delusional statement. She's human. She just felt that she was robbed of certain her previous qualities.
And she's not human because she's not properly grieving or reacting.
Because as if she's apathetic, oblivious, as if something happened to the stone or to the, to the object, and not to her beloved fiancé. She's not supposed to, and she knows, so that leads her to this experience.
But wouldn't, for example, is there the possibility that perhaps she was ambivalent and, you know, engaged, but not sure of herself? And so when is the fear and the wish kind of confused?
Well, that's a very good question. I think she had time to overcome her ambivalence. They knew each other already for about 5 or 6 years. So all this initial necessary question to be or not to be together were resolved. And she was really in tune for the wedding.
But a touch, perhaps, guilty that she might be relieved?
Could be. It could play a role. You know, it's a multifactorial, so certain doubts and certain events, of course, they contribute. I wouldn't discount it. Thank you for your suggestion.
Well, it leads to a different line of discussion, perhaps not in the first session, but later on.
Yeah, you're right. So initially, we always try supportive psychotherapy to explain and to help person, as you know, to release ambivalence and these negative feelings. For some reason, it rarely helps. I don't remember a case when my colleagues or myself were able, through the decent professional talk, to help a depersonalized person.
Okay. And in fact, what happened to this individual? What was the course?
She recovered. You know, in some cases where it's really acute and fresh, then the anti-anxiety agents in high dosages like lorazepam or alprazolam, Xanax, they really help. They really take it away. We gave her...
Well, no, she was admitted, you said, at some point.
No, this case, no, she wasn't.
Oh, she was not?
No, she was not, yeah. Xanax, short course of treatment by the Xanax helped. In her case, really, to give her 2 milligrams was sufficient to see that she perked up and she improved already. And then short term of the anti-anxiety agent and psychotherapy, so within a week and a half or 2, she was back on her feet.
So she was outpatient?
She was outpatient. It was brief intervention, basically.
And the outcome was, I mean, what did the intervention kind of enable her to do?
Well, she was able to resume her work. She was able to visit her fiancé, to participate in the handling of that emergency. Instead of being detached, immobilized, she became active, participatory, and she experienced appropriate range of emotions.
But you also commented that the suicidality is the reason they brought her. How did you handle that?
I think that when you reduce this, eliminate anxiety and detachment, they're so interconnected between each other. So you pull one, it's like a cluster, and you remove this suicidality. If there's no depersonalization, no anxiety, suicidality cannot stay separate from it.
Did you ask her about it, and do you contract with her? I mean, how did you...
Well, yeah, it's a different concept. The contract, I'm not completely supporter of the contracts of this topic. However, you know, I usually try to, it's okay to a certain degree to think about such a drastic measure. I don't surprise that you have suicidal thought, but it's, of course, it's wrong to do it. Thought and action, it's different. So if they need my permission, I give them some permission, acknowledge the pain, but then, of course, through the treatment, we eliminating the suicidal thoughts.
Well, but it takes a few days, so, I mean, how do you know after the first visit that...
She had huge relief after first visit, and Suicidality was really floating and transient, and it was impressive how improvement of the emotional and perceptual and the personalization state free her of suicidality.
So in your first visit, you were able to feel comfortable enough with letting her go home, and how long between the two appointments, for example?
It's just 3 days. It was really prompt, because you just sit and have a plan and you have a reasonable hope in what to do, give prescription. They come, and you, even in your presence, they can take that medication, because it's a hesitant what you're doing with me, and the result is evident. The result is evident. It's prompt, not always. There's, as I mentioned, antidepressants do not work. Powerful antipsychotics, including Zyprexa, for instance, do not work in depersonalization. There's in the literature data, it was surprising to me, I don't know how and why, but there's some work that clomipramine works in depersonalization. It's surprising to me, but there's a data that clomipramine, that's one, it works. I don't know how, but it works. So
not imipramine.
Not imipramine, anafranil. And lately, I read one article, and I did not try it myself. There's naloxone, the opiate receptor blocker. It works because of it really goes to the great matter of the mechanism of depersonalization. It blocks endorphin from ability to attach to the receptor sites, and it's interestingly, it's reducing, it's reverse this reduction of cortisol level, because what happens when you have endorphins, your cortical releasing factor is blocked, and through the hormonal ACTH, your cortisol drops. So people with depersonalization, they don't have much cortisol. Suppose instead they should have cortisol. And when you give naloxone, it's restored. And there was a case, I think, in this article, 4 out of 10 people, their depersonalization disappeared, and in the rest, it was substantially reduced.
By giving the
naloxone,
opiate.
Naloxone IV.
Well, you know, I think we'll have to take another break. They come quickly. And perhaps in our last segment, you can talk about the range of treatments that are available, that you employ, and we'll end on that. So we'll take a break. Thank you.
Yeah, the three.
I get this phone call from this insurance company. Normally, I don't pay any attention to these kind of calls, but it sounded like such a good deal.
What was the name of the company?
You know, I hadn't heard of it before, but all insurance companies are pretty much the same, aren't they?
How much money did you save?
The premiums were 1/3 of what I was already paying.
Sounds too good to be true.
Any insurance consumer is a potential target. If you believe you're being misled, contact the Massachusetts Division of Insurance, because knowledge is your best policy.
Isn't buying insurance supposed to make you feel safer?
All over America, people are taking the National Radon Test. Have you?
You put me on the spot.
Have you heard of radon?
I never thought about it. I don't know.
I think it's a secret killer or a silent killer.
Poison gas that seeps into the house.
That's one of the tests we did with the inspector before buying the home.
Why worry about it?
Why worry? Take the National Radon Test. True or false? Radon is the second leading cause of lung cancer.
True. I'd say false.
No, it's true.
I thought of cigarettes and then pollution.
That's something new to me.
Radon can penetrate a concrete block.
It's false.
False? False?
It's true.
I wouldn't know how they could protect you from that.
It's scary.
The Office of the Surgeon General recommends all homes be tested for radon.
False?
It's true.
True?
I should know about it because I worked in the hospital for many years.
So it's bad. We should get our house tested.
Sure, I'm gonna call it.
1-800-SOS-RADON. How can you not call?
1-800-SOS-RADON.
R-A-D-O-N.
Max, during the break you made a comment that we have to be delicate as we approach this fairly elaborate defense mechanism that these patients are employing, are using. Perhaps you could discuss that a little bit, and you also made the comment about, in some respects, you thought that we're asking them to do something that's not natural.
Well, the, you know, this powerful nature imposed this powerful defense mechanism, and for certain reason. It's really immobilized, but it also protects, though the personality is very uncomfortable. And at times when we very aggressively try to remove that defense, first of all, it's very difficult to do. And then at times it's really, instead of helping, it's just shifting situation in a problem of a higher magnitude. And what is dangerous...
Meaning
agitation, meaning suicidal behavior, a periods of hallucinations on delusion. And as if it's like comparison. Before, let's say, depersonalization disappear before its time, it's, in addition to just anesthesia, it became also alienation, estrangement, and projection. So these thoughts, which person felt as if they're just not real and not complete, and like his head is empty, they became somewhat else thoughts. They became like thought withdrawal or thought introduction, and that's dangerous. But nevertheless...
So that would be a psychosis?
Oh, yes,
okay.
Yeah. There's a cases when you remove depersonalization, usually on the early stages of disorder, and it's very delicate, possible, and helpful. When it stays, you really don't know for sure what will happen, improvement or explosion. It's like there's some surprise behind the depersonalization door. You can unleash psychotic forces which were contained by depersonalization. So it's, you have to wait, but there's no certain rules. It's your clinical intuition and common sense will help you. We will actively try to treat when the person is in acute distress, to such distress that they are hospitalized, where there's some suicidal thoughts, even if they're dim and they're not like complete, they're still. Because interestingly, by the way, you know that a group of our patients, they're self-mutilating. Some of them, they're really mutilating because they really depersonalized. Not all of them, of course. They try to prove and to feel, do they really feel? Is it really the skin? Are they here for sure? So this mutilation is like experiment to find out, do they really have feelings or not? And it's complex and intertwined with abuse and trauma and post-traumatic disorder, but at times it's just an extreme attempt to break through, to break free.
So doesn't that suggest that, well, for example, paranoid delusions, sometimes they're okay, but when at least the people who come to your attention, they kind of spread. So are you suggesting that this is not necessarily a it's a defense mechanism,
Yes.
but it may not always be successful, and in fact, it does result sometimes in a deterioration.
If you remove this defense prematurely, or it's not clear what's behind, so...
All right, but even before you remove it, what happens if you just leave it alone?
There's cases when it disappears spontaneously.
Mm-hmm.
I would say maybe close to 1/3 of them. They run for weeks or months and then go away for some unknown reason. But if it really stays, the longer it stays, then the more danger there is. In addition to build defense, it will become manufacturing mechanism. So instead of just,
I'm sorry, I missed that.
like producing, like a factory, manufacturing.
Okay.
It's instead of just protecting and insulation, there will be some construction of truly psychotic symptoms. So it's good and potentially bad. We have to be always on lookout and watch for the unwarranted developments. Easier said than done.
Mm-hmm. So, for example, the cases where there's not a quick recovery, how do you remain vigilant? What do you do exactly as a outpatient treater?
We continue supportive interview discussion. I try to cognitively to explain people that they're suffering not in vain, that there's some good sense attached, that this is price of being detached. It helps them to preserve what they have, and when they will restore homeostasis and equilibrium, that most likely will go away. It's going away usually when it's attached to anxiety. When you, through psychotherapy or time, and person themselves, you know, they have always thinking, even depersonalization. Our thoughts are never stop. It's like our heart, thinking, reviewing, and something click, and they feel safe and free, and certain biochemistry behind it comes to the good conclusion, and this is one day they wake up and it's a clear sky. In other cases, and there are cases, let's say, of schizophrenia, which start as depersonalization, their comparison of their somatic perception became more unusual. It goes into their somatic delusions. Then you'll see that it's time to launch an attack, not an attack, but to launch the really more new forms of treatment. Meaning, so you accept that you could not stop depersonalization, but at least you will stop these budding delusions and hallucinations. Then you use appropriate antipsychotic, could be Zydis, could be Giadan, Risperdal. I use more for some reason, Zyprexa slightly more. But all these atypical and antipsychotic, they later they have a chance, though lesser chance, that minor tranquilizers, anti-anxiety agent in the beginning of the process also to reduce depersonalization, but to lesser degree. It's not good development when the depersonalization stays with hallucination, delusion, because eventually, and if we have time, I can share you my thoughts about it, really leads to exhaustion. It's like coagulation, and there's all these negative symptoms appeared. What was a fire like a volcano became really like ice, like really some substance after eruption.
So when your intervention is successful and somebody kind of goes back to the beginning, for some people, isn't that a beginning where there might be a host of problems? In other words, not everybody is necessarily functioning optimally before, say, the trauma.
Yeah, well, it's like it was a critical experience, and we have to use this crisis to devise certain strategies and certain expectation how to handle what if, and usually it's comes something new will come. There was once your life was full of stresses. So you cannot completely eliminate the risk of new episode of depersonalization, but I believe that you can reduce it through educating person to show them their limits and their strength, give them feedback that they're not alone, and that's really reducing risk, but we cannot give guarantee that it will never come again.
But someone whose relief is quick, do you continue to follow those people, or do you just have them call you?
Yeah, I follow them for a month or two, then I think it's sufficient. I believe you can handle things without my help, but I'm available. Give me a call if you feel that something is growing, because we know that it can grow into the numbness and immobilization. So we have to really talk. And our talk is also not just informational, psychological, there's some biological side to it. So therefore, by talking, we tune in our biological features as well.
Do some of these people, for example, go back to, say, mild to moderate depression after the episode of depersonalization?
It was not my experience, no. If they go away, it's really improvement, lengthy improvement. If there's not improvement, then it goes to the protracted refractory depression. Because initially it's really anxiety and depersonalization. Later it's depression and psychosis and delusions. And I think to me it's interesting because it's like a general, non-specific process to try to explain why this tree of mental illness, how it's really developed, what's going on. It's not a chaos. It's not only chaos. There's certain rules in this development, and then it's really happened to the Russian immigrants, not because they're exclusive.
I was going to just ask, because we have to wind down.
Sure.
We have 1 minute. Are there cultural issues?
Yeah, but I don't think that it's exclusive to Russian culture. Absolutely not. It's all human beings, whatever their background, are vulnerable and potentially can do it. But Russian immigrants, it's one of the examples. Then they go through the ambivalence of immigration, the stress of immigration, identity crisis, little such unusual small crises as are they covered by Medicaid? Will they be citizens? Will they pass citizenship exams? There's all these little things can break and break their stability and invite, not always, in some cases, depersonalization.
All right. Well, listen, it's been fascinating and very nice to kind of visit kind of psychodynamic thinking about issues, even though obviously you're suggesting a biologic component. So on behalf of the Norfolk Alliance for the Mentally Ill, Max, I want to thank you for being here today and very much appreciate our discussion.
Thank you for the invitation.
My pleasure.